Alicia. I identify as she, her, and I'm here to discuss childhood or pediatric asthma. So pediatric asthma, essentially the approach that we have taken is that we are addressing common questions that parents may have when it comes to treatment and management of pediatric asthma. So we've kind of covered a lot of the different questions that are pretty common when parents find out that their child may have asthma. So for instance, what is asthma? Asthma is an inflammatory disorder. It's a chronic condition that results in airway inflammation, bronchoconstriction, and increased mucus production. These changes can be caused from genetic factors like family predisposition, environmental factors such as like smoke exposure or other air pollutants. It can be a result of early life viral infection. So for instance, RSV early in life can result in chronic inflammation of the lungs. Other things like immune system development disorders, so like autoimmune conditions or allergies can significantly increase a child's likelihood that they'll develop pediatric asthma. Asthma, the symptoms are typically wheezing, coughing, difficulty or shortness of breath. Increased work of breathing is common amongst all patients with asthma. And of course, too, that children are more susceptible because of their immature lung function and generally are more susceptible to other viral illnesses like rhinovirus, which is the common cold, which can exacerbate symptoms on the regular. So we talk about how we can manage symptoms, and there's the standard approach, which is prevention and relief. Prevention is a daily regular medication taken, such as an inhaled corticosteroid like Flovent, which is used to help reduce inflammation. It works locally within the lungs, so it's quite safe to administer to a child when used properly. Corticosteroids are taken every day. Their effects might not be kind of really initiated until about a few days starting treatment. And of course, too, they're longer acting, so they'll help reduce the inflammation over a long period of time. However, with inhaled corticosteroids like Flovent, we do patient teaching in regards to washing their mouth out after doing their inhaler, because corticosteroids can lead to things like oral thrush, which are yeast. So, kids will get like a white kind of coating over top of their tongue and around their mouth, and that's indicative of thrush and requires some treatment for that. However, the gold standard, MDI spacers are the gold standards. And here in PMH, and actually most of Canada uses the Aero chamber because it is a Canadian product. I'm not promoting any products here, but it is what we use. Essentially what it is it's a single valve, so it allows the medication to be administered and then they're not blowing back out. So they're able to exhale through a different valve, and it's anti-static. So what happens is we don't need to try and coordinate our breath with a child, especially one who's probably not going to be super compliant to, the traditional way we might have seen it on a video where we have a kid, trying to suck it back and get relief from their asthma symptoms. But the MDI spacer eliminates the inability to breath coordination. So it allows the medication to float, allows the patient and to be able to take a few breaths and get the full dose of the medication. So in that being that said, is that it actually reduces side effects such as oral thrush, because the medication is being delivered to the lungs and not just sitting in the oral mucosa when we have a poorly timed inhaler. So they say that 80% of people incorrectly use their metered dose inhalers. So that is a very surprising fact that I found. I did not realize it was that high. Typically, we as nurses, we're doing a lot of patient teaching. So one of my approaches, working in the emergency department, I am a bridging student, I will often ask my patients, how are you using your inhalers? Can you show me? So we talk about the demonstration aspect of things to kind of identify any barriers or any concerning actions so we can get better control of one's asthma and reduce exacerbations, reduce hospitalization. So that's kind of the approach, is like, let me see how you're doing it, and then we can provide patient teaching on how we actually, or should, the best practice of using inhalers. When a child presents into an emergency department, we have a standardized approach called the Pediatric Respiratory Assessment Measure. It is a validated tool that we use to identify the severity of a child's asthma exacerbation from mild, moderate to severe. It also is a really good guide to determine whether or not a child will have hospitalization when they first present. It also will help, it's a consistent measurement that we're able to utilize upon reassessment following treatment. So that measurement that we get, the higher the number, the worse the exacerbation is, the more severe it is. So that number will help us guide and choose a pathway. So TREC, Translating Emergency Knowledge for Kids, offers excellent resources, pathways, and clinical recommendations for best practice treatment of asthma exacerbation with pediatric patients. And so determining their PRAM score will help you determine if it's a mild, moderate, or severe, and that'll help guide your pathway, whether we're giving nebulized, so wet nebulized treatments, or if we're just using our rescue inhaler, such as Ventolin, with the MDI to deliver the medication. These act by smoothing this, relaxing the smooth muscle of the airway to help open them up so we can get more in. A common thing that I've seen as well when it comes to patient teaching is that patients, again, where the ask for demonstration works, is there will be stacking. So 1, 2, 3, 4, and they're thinking that's the same as 1, we wait, and then within 30 to 60 seconds administering another dose. The idea is that the bronchodilators go in, they'll open up the airways a little bit, allowing the next dose to get deeper and further. So it's a compounding effect when we provide these medications. But essentially, PRAM scoring guides that emergency department treatment and how we kind of manage it. So it is essential for that. Overall, we talk about family teaching in regards to addressing triggers for kids. Sometimes it's exercise, colds, cold weather, air, smoke. I know, for instance, over the summer, wildfire smoke was significant and caused a lot of asthma exacerbations. So, of course, identifying those triggers, doing what we can to mitigate those risk factors, improving ventilation or removing mold in a home or addressing those kind of socioeconomical factors kind of help promote overall asthma well-being and reduces the risks of hospitalization and emergency room visits for pediatric patients and for adults as well. So we ask about, is asthma curable? It is not curable. It's a chronic condition, but with proper management and identifying those triggers, we can reduce the frequency of exacerbation, but children can go into remission, or we commonly say they've outgrown their asthma. The condition, although is not cured, it will always be there. Sometimes patients later in life will have conditions that, like for instance, a viral illness, they get influenza, they get rhinovirus, and they're unwell, and they'll have an exacerbation of their symptoms. They'll have to use, so like myself, I had asthma as a child, and today if I have a cold or other things like a significant exercise, high altitudes, I do require my rescue inhaler, my Ventolin. The biggest thing right now that I'm kind of advocating for is, yes, teaching as a nurse, but also policy advocacy and support of individuals with socioeconomical factors that are impacting their ability to care for asthma and reduce the severity of their exacerbations. So World Asthma Day is actually on May 5th. Their idea is that access to anti-inflammatory inhalers for everyone with asthma is still an urgent need. They estimate 500,000 people die each year from complications. The majority of those are in third world or other low economic status areas. That being said, it has a large factor to do with whether or not we're doing prevention and relief. Typically, relief is a lot cheaper. And what will happen is people will be rationing their preventative medication, their Flovent, and so they're not getting that adequate anti-inflammatory effect. And then they're relying on their reliever a lot more. And actually doing that will result in desensitization of the airway to those short-acting beta agonists. Those are the medications that smooth that relax the smooth muscle. And so then what happens is patients need more of it more frequently, which then of course will complicate matters as we go on, right? Because we've been desensitized, no longer 2 puffs, now it's 4 puffs, now it's 8 puffs. Now we're in the emergency department and we're requiring magnesium to help relax that smooth muscle. Now we're requiring stronger medications. But perhaps we live in an area where you don't have access to those resources, like an emergency department that's prepared, or other healthcare provider like a regular family physician. Those things can kind of get missed, which then results in that morbidity and mortality rate that we are kind of seeing in those impoverished areas. But essentially what I really love is the patient teaching fact, but also promoting self-advocacy and health literacy for parents and patients. And one way we can do that is development of an asthma action plan. Essentially, this form here has been provided by the Alberta Health And it's essentially a guide to help identify different triggers, different symptoms, and the mechanisms that we will do to intervene. So for instance, a parent may say, okay, so my child is having some nighttime use, they're having some symptoms such as coughing when they're trying to sleep, and then we can guide what we're going to do about that, whether they're going to take the reliever inhaler, they're going to contact their primary care provider because they're requiring the reliever more often, which will help reduce overall hospitalization and emergency room use. But it also empowers a parent to feel confident in treating their child's asthma. So the essential part is MDI spacers are the gold standard of care, okay? And, following the asthma action plan, having one in place and asking questions, seeking out resources is imperative to overall productive childhood management of asthma. I intend on applying for my master's in nursing. I would love to be a nurse practitioner and also educate. So I would love to be an instructor. I'm really passionate about education, whether it's patient-based, nurse-based, public-based. I'm quite passionate about education. I think I do a good job.